Chapter, we're going to talk about pharmaceuticals. Pharmaceuticals, when we're talking about pharmaceuticals, we're talking about chemical names, and sometimes they're difficult to say. And nobody knows how to pronounce them because unless they have advertisements on television, you really have no clue how to pronounce them. So if I stumble over them, I apologize. Most of the common names are not that difficult. So let's go ahead and get started. There we go. Psychotropic medications, we're talking about the pharmaceuticals that we use that doctors will uh, prescribe to people with mental illnesses. We're going to start out with SSRIs, selective serotonin reuptake inhibitors. How do they work? Um, this really tells you how most pharmaceuticals actually function. SSRIs inhibit serotonin reuptake so that they increase synaptic serotonin levels. Many SSRIs affect other receptors, especially at high doses. SSRIs clinical effect usually takes weeks so that the mechanism goes beyond simply increasing synaptic serotonin levels. There are several serotonin receptor subtypes. Serotonin receptors are located throughout the body, especially in the GI tract, so it's in our guts. One of the things that's happening up here in Iowa is that we have a lot of pollen floating in the air, and sometimes it's irritating and sometimes it's not. I don't really have an allergy, but there's and not only that, but there's a storm moving in. So if I sound a little congested, it's uh, it's because of the excess pollen, which is a good thing because I have an orchard and I need pollen. I need apple pollen, apple blossom pollen in the air in order to have apples this year. So there you go. We're supposed to have a storm. We've been having really bad weather over the last 3 or 4 weeks. We've had three tornadoes in this area, each week, and we're going to have another thunderstorm tomorrow night. So we'll see what happens. Indications and off-label uses: all selective serotonin reuptake inhibitors except Luvox are FDA approved to treat depression, major depressive disorder, and dysthymia. Dysthymia is mild depression. It's they talk about it as if it's blues every day. You just feel blue. It's not severe depression. It's not in-depth depression. It's just not feeling real zippy every day. Various class members of SSRIs are also approved to treat generalized anxiety disorder, OCD, panic disorder, PTSD, eating disorders, premenstrual dysphoric disorder, and social anxiety disorder. Off-label uses, they use it for ADHD, they use it for insomnia, uh, chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia and intellectual disability, just to temper their behavior. The half-life of SSRIs, short half-life, missed doses can result in uncomfortable symptoms. That includes Paxil and Luvox. Moderate half-life, Zoloft, Celexa, and Lexapro. And long half-life, that's Prozac. And that's why Prozac was so popular, or is so popular. It's good for people who may miss doses. Prozac has been the leading medication, leading selling medication in the United States for a while, and then it was overtaken by the erectile dysfunction medications, especially Viagra. Side effects of SSRIs: decreased sex drive and impaired sexual function. tend not to resolve with time. This is a problem that is perpetual. Nausea, diarrhea, anorexia, and vomiting all will increase with dose and can resolve with time. Weight gain, especially Paxil, paroxetine, after initial GI effects, headache, dizziness, anxiety, especially Prozac, fluoxetine, rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially Paxil, paroxetine, bruising, increased prolactin, a protein that enables females to produce milk. So this can be a problem. Drug-to-drug interactions, Luvox increases Prozac, increases Paxil, increases Zoloft, increases Celexa, increases Lexapro. The interacting effect may be dose dependent in Zoloft, in SSRI levels tend not to be altered by other drugs, but can potentially increase levels, inhibit metabolism of certain drugs, so it slows down the metabolism of other drugs. So if you are taking an SSRI with another medication, you need to tell your doctor because sometimes it will interact with that drug. Um, Paxil increases risperidone, which is an antipsychotic. Prozac will increase buspirone, which is an anxiolytic, an anti-anxiety drug. And Luvox increases olanzapine, which is an antipsychotic medication. Um, Cautions suicidal ideation and increased suicide risk, especially with children early in treatment, but there is significant debate about this. Serotonin syndrome, SSRIs, if you're taking an SSRI with a monoamine oxidase inhibitor or possibly lithium, there may be other problems with other medications that there is a situation they refer to as serotonin syndrome, diarrhea, tremors, sweating, restlessness, hyperreflexia leads to a progression of symptoms if untreated. Then the individual will go into disorientation. They will become fairly catatonic. They become rigid. They will have a fever that will lead to a coma, and then they will have seizures that lead to death. Serotonin syndrome is one of those things that you start getting diarrhea, tremors, and sweating and restlessness, and you need to start thinking about stopping treatment because about 10% of people that have it, that develop serotonin syndrome, will die. Many medications, substances have serotonin activity. The cough medicine dextromethorphan will make people feel better. Fentanyl, which is an opioid, of course, also makes people feel better, which is one of the reasons why people take it so much. Meperidine, which is Ritalin, it's an opioid commonly called Demerol. Oh, meperidine is Demerol. I'm sorry. Somatriptan is a migraine medication, and it can make people feel better. St. John's wort is an herbal antidepressant, and you need to be really careful if you're taking St. John's wort because you can develop serotonin syndrome if you're taking St. John's wort with an SSRI. MDMA, ecstasy, LSD, all of these, most of the hallucinogens will increase the serotonin level, and that's why they work. Citalopram, also known as Celexa, it has few drug-to-drug interactions, has high serotonin specificity. It's typical or less selective serotonin reuptake inhibitors. Side effects: escitalopram, Lexapro has no generic. There is no generic available for this one. It has simple dosing. Fluoxetine, Prozac, Seraphim, Symbyax with Zyprexa. Very long half-life. Prozac is the SSRI that stays in your system the longest. It has significant drug-to-drug interactions. That's one of the reasons why, if you're taking Prozac, that you need to make sure all of your doctors know exactly what you're taking. Fluvozam, Fluvozamine, Luvox. It is used for OCD, multiple significant drug-to-drug interactions. Paroxetine Paxil has significant drug-to-drug interactions. Some reports of associated weight gain with Paxil. Withdrawal symptoms with missed doses, so you need to be really careful that you take your Paxil. Sertraline, Zoloft has moderate to drug-to-drug interactions and multi-step dosing. So Zoloft is usually used with women who have postpartum depression. The medication they use is Zoloft because it doesn't get into the milk, the mother's milk, like Paxil and Prozac. Neuroantidepressants that are not less serotonin specific or affect serotonin differently than SSRIs. Desiril in 1981, also known as Trazodone, it's used for people with PTSD. 1989, Wellbutrin, bupropion. Wellbutrin is not specific to serotonin, and it doesn't have sexual side effects. 1993, Effexor, venlafaxine. 1994, Cerazone, Nefazodone. 1996, Remeron, mirtazapine. 2004, Cerazone was discontinued, although there are generics available. And Cymbalta, duloxetine, is another atypical antidepressant. Mechanisms of action, Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors, SNRIs. Remeron has serotonin subtype and norepinephrine activity. Trazodone and Nefazodone have different serotonin activity than SSRIs. Bupropion has a dopamine and norepinephrine activity, giving you a pretty good buzz. Indications of off-label uses, all typical and atypical antidepressants have FDA approval to treat depression. SNRIs have been shown to be effective in chronic neuropathic pain. Wellbutrin has been approved to treat nicotine addiction. Wellbutrin can augment SSRIs to reduce SSRI sexual side effects. Remeron and Trazodone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical selective serotonin reuptake inhibitors. Wellbutrin, Remeron, Trazodone, and Nefazodone do not usually have associated sexual dysfunctions. Venlafaxine, Effexor, is similar to tricyclics with less safety and side effect concerns. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. As an SNRI, Effexor activity depends on dose. Effexor has a minimal drug-to-drug interaction. Effexor has side effects with missed doses. Duloxetine, Cymbalta is an SNRI that has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion, Wellbutrin, Zyban is a norepinephrine and dopamine reuptake inhibitor. Zyban is used to treat Smoking addiction, bupropion is a seizure risk in certain patients, increased risk with high doses. Bupropion's drug-to-drug interactions are not often significant, except with monoamine oxidase inhibitors. And we're going to talk about monoamine oxidase inhibitors. Really dangerous stuff there. I'm not exactly sure why. I guess sometimes SSRIs don't work. Sometimes tricyclics don't work. So they give people monoamine oxidase inhibitors, but the side effects and the possibility of fatality with monoamine oxidase inhibitors is fairly significant. Sorry. Mirtazapine, Remeron. Mirtazapine is a complex serotonin that has norepinephrine alpha 2 and histamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has sedation and weight gain, especially at lower doses. Mirtazapine usage can have lipid abnormalities. Remeron has minimal drug-to-drug interactions except with MAOIs, of course. Nefazodone, Cerazone is rarely used due to irreversible liver toxicity. Nefazodone was pulled from market by initial manufacturer in 2004, although it is still available as a generic, as weird as that sounds. Nefazodone is still popular with some patients because it works for them. Trazodone or Desaril causes sedation, weight gain, low blood pressure. Trazodone is used most commonly off-label for insomnia. Rare reports of sustained painful erection, priapism, that can be treated in the emergency room. It can lead to impotence if you're not careful. It has been reported with trazodone. Tricyclic antidepressants describe a group of drugs with similar structure and function. They are abbreviated TCAs. They were first discovered in 1958. Imipramine, it was supposed to be an antipsychotic, but it was found to have antidepressant properties. And this was a good thing because this is one of the first antidepressants that they actually discovered. In the 1960s, multiple other TCAs developed and placed in use, and we're going to talk about some of the other tricyclics. Imipramine was the first, but there's a bunch more. 1990s, significant reduction in use due to introduction of SSRIs, which have fewer side effects. I can remember when I was working in the laboratory, we had to measure people's TCA levels, no matter what it was, what type of tricyclic they were using, because it can build up in your system and it can become toxic. So when the SSRIs came out, everybody was happy, especially the people with depression, because they didn't have to go and have their blood drawn every month to make sure the imipramine wasn't building up in their system. The mechanism of tricyclic antidepressants, there is a norepinephrine, serotonin, histamine, muscarinic, cholinergic, and alpha adrenergic receptor activity in differing ratios. Anticholinergic activity leads to many of the side effects of these drugs. It is used for depression and a similar spectrum of disorders as SSRIs. Actually, the SSRIs took the place of almost all tricyclics. Some people don't react to SSRIs, and therefore they do have to take tricyclic medications. Tricyclics are especially helpful with chronic pain and depression secondary to medical conditions such as AIDS. Side effects include enuresis, narcolepsy, premature ejaculation, insomnia, and migraine prophylaxis. Blood may be obtained to monitor dose effectiveness, and that's what we were doing back in the 1970s. Drug-to-drug interactions for tricyclic antidepressants, TCAs, have multiple significant interactions in each direction with potentially serious consequences. And this is one of the reasons why most psychiatrists switch to SSRIs. There is a problem with tricyclics. Side effects of TCAs for anticholinergic problems include dry mouth, constipation, blurred vision, and urinary retention, cardiac arrhythmias and conduction changes, orthostatic hypotension, sedation, and weight gain. Cautions when taking tricyclic antidepressants, overdose is frequently fatal, which is another reason why SSRIs replace tricyclics, and patients with bipolar disorder may be pushed into mania or rapid cycling, and this is another reason. They were trying to use TCAs to control the depressive episodes that bipolars were having, people with bipolar disorder were having. And what they were doing is pushing them into mania, into the manic phase. Amitriptyline Elavil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and it's high in pain control. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. It's used to treat OCD, depressive disorders, panic attacks, and anxiety. Disipramine, these are all more tricyclics. Norepinephrine is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects. It blocks acetylcholine, and it's low in pain control. Disipramine is used as an antidepressant and to treat ADHD. Doxepin Sinequan is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and it's low in pain control. Doxepin is used to treat major depressive disorder, anxiety disorders, chronic hives, and insomnia. Imipramine, tofranil, this is the first one, is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and moderate in pain control. It is used to treat depression, anxiety, and panic disorders, and enuresis. Amoxapine ascendin is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Amoxapine works as an antidepressant rapidly in 1 to 2 weeks. And you got to remember that SSRIs takes 5 to 6 weeks for them to start working. It has been used as an antipsychotic. Uh, Clomipramine, anafranil, is low in norepinephrine activity, high in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and it's high in pain control. You may wonder why some of these chemical names are easier for me to pronounce, and the answer is because I have dealt with these before. The ones that I've dealt with, some of them are fairly rare or they're relatively new. And of course, when I was working in medicine, um, we heard these names all the time: anafranil, ascendin, clomipramine. Yeah. So some of these I've heard before, some of them I've dealt with before, and others I haven't. And the ones that I haven't are a little bit more difficult for me to pronounce. And some of these names just bounce right out of your mouth, and some of them get stuck. Meprodoline luteamil is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and moderate in pain control. Meprodoline is used to treat depression, anxiety, panic disorders, and neuropathic pain. Nortriptyline, Pamelor, is moderate in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and is moderate in pain control. Nortriptyline is used to treat depression, anxiety, ADHD, neuropathic pain, and to help in smoking cessation. Protriptyline Vivactyl is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Prototriptyline is used to treat depression, ADHD, and its energizing effect is used to treat narcolepsy. Trimipramine Sermontil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects, high in pain control. Trimipramine is used to treat depression, anxiety disorder, psychosis, and insomnia. So when I was working in the lab, we had to draw these medications, and we had to draw blood to measure the tricyclics, the TCAs, and that's one of the reasons why I've seen all these medications. Now we come to the monoamine oxidase inhibitors. Monoamine oxidase inhibitors were actually came before the tricyclics, but it had such horrible side effects that as soon as the tricyclics hit the market, the monoamine oxidase inhibitors kind of went away. Now the problem is not everybody reacts to tricyclics, not everybody reacts to SSRIs. And if that's the case, then the next thing that they have to do is to try the monoamine oxidase inhibitors. And that's why this medication is still being used. It's for the individuals that don't react to the other two types of antidepressants. Because the fourth option is electroconvulsive therapy, sending a electrical charge through the brain. Not popular with anybody. That's probably the last resort. So SSRIs only work about. We keep getting bad information about this. When SSRIs first came out, they said, "Oh, 90% effective," and then we found out, well, that's not really true. It's only about 3/4 effective, 75%. And then we're going, oh, wait a minute. I don't think that's true either. Let me see if I can find the efficacy of SSRIs. And we were getting bad information from the pharmaceutical companies. Oops. We may not. 30%. There you go, about 50%. And that's the last figures that I've heard as well, 50%. So, yeah, that's not really good. So, if only 50% are using it, are actually being helped with SSRIs, the next treatment is tricyclics, TCAs. And TCAs usually work on just about everybody, but the problem is its side effects. And some people have to stop taking them. What are you going to do with the depression? Then you start treating them with monoamine oxidase inhibitors. And we're going to talk about some of the side effects of monoamine oxidase inhibitors in just a second. Monoamine oxidase inhibitors, abbreviated as MAOIs, they were first discovered. It was an they developed it as an anti-tuberculosis drug. They discovered that, hey, it works on depression, but it doesn't work on tuberculosis. This was in 1952. In 1962 investigation, they started using it as an antidepressant. And then in 1958, the tricyclics came out. You've got to understand that a lot of these pharmaceutical companies don't brag about the fact that they have side effects. And so it took them 10 years before they realized there's an awful lot of people that are having problems with monoamine oxidase inhibitors. Investigation of a death from hypertensive crisis by someone ingesting tyramine-rich foods while taking an MAOI. Now you got to understand that there were other people that died, and they just didn't do anything about it. They didn't really investigate. In the 1960s, institution of strict dietary restriction by tyramine containing foods and other interacting substances. We're going to talk about tyramine in just a second. It's a lot of different things. Significant reduction in use due to introduction of tricyclic antidepressants, which do not have the severe restrictions of MAOIs. This happened in the 1960s. Now we have a transdermal patch known as MSAM, selegiline, to treat depression if they don't react to the TCAs or to the SSRIs. Oh, sorry. Come on. So these are the problems with monoamine oxidase inhibitors. There's a risk of suicidal thoughts. They a lot of serotonin syndrome, antidepressant discontinuation syndrome, food interactions causing high blood pressure, which kills you. Features of MAOIs. MAOIs are an effective antidepressant for those who can adhere to the necessary restrictions and tolerate many other side effects. Very long duration, requiring caution when mixing with restricted substances or medications. Tyramine containing foods, not a complete, this isn't a complete list, but I mean, it's a lot of different things. Certain tyramines may be consumed in moderation, but many cheeses have tyramines, chocolate, soybeans, hot dogs, dry sausage, caffeine, beer, wine, pickles, olives. You got to stay away from a lot of foods. Drug-to-drug interactions with MAOIs, multiple prescribed and over-the-counter medications can be potentially lethal. They have, what happens is their blood pressure skyrockets and they literally cook themselves to death. Serotonin syndrome with SSRIs and many others. And this is one of the reasons why if you're taking an MAOI, you don't want to take any other medications. It's just too dangerous. Excuse me. Okay, these are the MAOIs. When they first came out, these were the ones that Nardil, Marplan, and Parnate are the three main MAOIs. Nardil is phenylzine. Marplan is isocarbomoxide, moxazide, and Parnate is tranylcypromine, tranocyclopromine is Parnate. Interesting because this is the first antidepressant that came out, and everybody knew Nardil, Marplan, and Parnate, but it fairly quickly became less common as people were taking it. And then you had imipramine, desipramine, nortriptyline. All the TCAs became more popular. Similar medication is selegiline, Eldepril. Selegiline is used to treat Parkinson's symptoms. It's a selected B inhibitor at low doses, so restrictions are not critical. At high doses, acts like a typical MAOI, and so there is need for food restrictions. And there's your food: the cheeses, pickles, olives, sausages. You have to stay away from caffeine. Recently available as a transdermal patch known as MSAM to treat depression and not needing food restrictions at low dose, although still drug interactions. Reversible selective A inhibitors not available in the United States. There are no restrictions on those. Okay, we're not going to talk about MAOIs anymore. It's really a dangerous drug, MAOIs, and unless there's no other option, then most psychiatrists and psychologists stay away from MAOIs. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used in the treatment of acute mania versus prophylaxis versus depression. Lithium, carbamazepine, and valproic acids. Lithium is a salt. It's a heavy metal, but they put it in salt. Lithium chloride. They they tried to put lithium. They tried to they Sodium chloride, of course, is salt. So they decided, hey, we've got a lot of people who are bipolar. Maybe if we just made lithium salt and put it on the market, that we wouldn't have any more problems with bipolar disorder. Real bad idea. Real bad idea. Became toxic fairly fast. Lithium was recognized as an anti-manic. It works on mania, so that's why it works with bipolar disorder. They decided to put it in salt as a substitute for the sodium in salt. Too much, too many people. Real serious problems with the toxicity. In 1966, French researchers demonstrate the valproate's efficacy in treating mania. Valproate, of course, is an anti-seizure medication. Significant studies demonstrate lithium's efficacy in bipolar disorder. So, at first, they were using lithium to treat the manic people who were manic, and then they realized that they could actually use it for manic depression, which is what they called bipolar disorder back then. 1980 studies demonstrate effectiveness of carbamazepine in bipolar disorder. Carbamazepine is another anti-seizure medication. Carbamazepine and valproic acid. There should be a comma right there. The features of lithium. Lithium is the only mood stabilizer without significant anticonvulsant properties. Up to 70% will respond to lithium, people with bipolar disorder. Lithium has demonstrated effectiveness in reducing suicidality. It's less effective in rapid cycling in mixed bipolar states. It has full clinical effect, may take up to 1 to 2 months, which can be a problem. Serum levels guide dosing, excreted through the kidneys. It's a heavy metal, remember. We complain about people getting too much sodium in their diet. Sodium, of course, is a heavy metal, and it has to be excreted through the kidneys. Minimal liver-mediated drug-to-drug interactions with lithium. The side effects of lithium, fine tremors, weight gain, nausea, increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. Increased risk of toxicity with fluid or salt restriction. Hot weather, the individual sweats more than normal. Use of anti-inflammatory drugs. ACE inhibitors and angiotensin receptor blockers and diuretics. Those are things you have to be careful of. And this is one of the reasons why all your doctors need to be aware of what's going on here. It may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of creatinine BUN and TSH. That's your thyroid functioning, your kidneys and your thyroid. Creatinine and BUN tell you how your kidneys are working, and TSH tells you how your thyroid is working. Females are at much greater risk of lithium-related thyroid dysfunction, so you've got to be careful. Carbamazepine, also known as Tegretol, it is an anti-seizure medication. It's used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. It's less effective in bipolar-related depression. Serum levels can be helpful in guiding dosing. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing carbamazepine levels. A lot of times, for bipolar disorder, the individual will take both anti-seizure medications, Tegretol and valproic acid. It induces its own metabolism, so it may need to adjust dose over several weeks. Side effects of Tegretol, carbamazepine, gastrointestinal problems, nausea, constipation, diarrhea, appetite loss, central nervous system effects, sedation, dizziness, unsteadiness, confusion. Benign rashes are common. Catastrophic rashes are rare, but they do occur. Many possible serious abnormalities in your complete blood count. Your complete blood count is your hematocrit hemoglobin, it's your white count, your red count, your thrombocytes, your platelets. That's the CBC. It may reduce sodium levels, hyponatremia, and this can be a problem. Hyponatremia is if you drink too much water, then you will dilute out your blood and your sodium levels will be too low. If this happens, it can cause a psychotic reaction for the individual. If you drink too much water at one time, you'll get water poisoning, where your sodium tanks and potentially it will kill you. That's known as hyponatremia. That's one of the reasons why if you're running a marathon, they tell you don't fill up on water because it'll dilute out your blood and you could fall down dead. I know, poisoned by water, besides drowning, of course. Liver function abnormalities are rare, but they are possible. Toxic metabolite, 10 to 11 carbamazepine epoxide, can create problems via drug-to-drug interactions, valproate, lamotrigine, and phenobarbital. Independent of carbamazepine levels can be checked separately. There's your Depakote, your valproic acid. It can be dosed rapidly to treat acute mania. It is more effective than lithium in rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and other psychiatric disorders. It's approved for migraine prophylaxis. Prophylaxis means keeping something from happening. Serum levels can be helpful in guiding dosing, commonly used at top or above levels stated for seizure control. Of course, it's an anti-seizure medication. Some suggest supplementation with carnitine, selenium, and others to reduce side effects. Excuse me. The side effects of valproic acid or Depakote, nausea, weight gain, unsteadiness, ataxia, hair loss, and tremors. Liver dysfunction, decreased platelets, thrombocytopenia, that's decreased platelets, which means that you bleed easily and it's hard to make it stop. Pancreatitis is rare but potentially serious, of course. It can lead to pancreatic cancer. Polycystic ovary disease, suggested by some reports, ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. Lamotrigine, oxcarbazepine, topramate, levetiracetam, and zonisamide. Wow, there you go. Lamotrigine was investigated in the 1990s for mood stabilizing properties after patients on it for seizure disorders reported benefits. In the 1990s, that's when they discovered this stuff. Most newer approved anticonvulsants are investigated for mood stabilizing properties. In 2003, lamotrigine was approved for bipolar 1 maintenance. Lamictal is another name for lamotrigine, minimally sedating, unlike most other mood stabilizers. It appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children raised concerns about potentially life-threatening rash. This is known as Stevens-Johnson syndrome, also toxic epidermal necrolysis. Necrolysis means that the skin is dying. Initiating lamotrigine is done very slowly to decrease rash risk. Valproate greatly increases lamotrigine levels, so you need to be really careful. You can't. These are two anticonvulsants you can't really mix. Valproate and lamotrigine. Carbamazepine greatly decreases lamotrigine levels, so you can't really see what you normally do when somebody's got bipolar disorder is you give them two anticonvulsants, anti-seizure medications, but you can't tie lamotrigine to anything else, to any other anticonvulsant. Oxcarbazepine trileptal is used primarily in combination with other mood stabilizers, although efficacy is not clearly substantiated. It's modified carbamazepine with potentially less side effects and drug-to-drug interactions than carbamazepine. 1011 carbamazepine epoxide, not a metabolite, so higher doses required, is switching from carbamazepine. Topiramate, Topamax. Research questions its use as a mood stabilizer, although scattered reports suggest possible benefits. People on this like it because it causes weight loss, but it does make cognitive dulling, frequent kidney stones, metabolic acidosis, not good ideas. Levetiracetam, Keppra, its efficacy in bipolar disorders unsubstantiated, although scattered reports suggest possible benefits. Minimal drug-to-drug interaction. Zonisamide, Zonegran, efficacy in bipolar disorders unsubstantiated, although scattered reports suggest possible benefits. Side effects similar to topramate include weight loss. Olanzapine and fluoxetine combination, also known as Symbyax, it has been approved to treat bipolar disorder. It's a mixture of anticonvulsant, that's the olanzapine, and the fluoxetine, of course, is SSRI. Okay, now we're going to talk about antipsychotics. Chlorpromazine was the first one that they discovered. You got to remember that people have been, one of the reasons that psychology became psychology is because we had so many people with so many really serious problems. The most serious problem, of course, was schizophrenia. They were uncontrollable, and these individuals had to be institutionalized. And this has been going on since time immemorial. There have been people that had such severe psychotic reactions that they were either killed or they were institutionalized. And so that's one of the reasons why psychology focuses on all focuses focused on the negative for such a long time. It wasn't until about 2000 that we started pushing positive psychology. So here we have all these individuals that are institutionalized. We're trying to get them out. And then in 1950, chlorpromazine hit the market, and we realized that it worked and that it reduced the psychotic uh, episodes, meaning that some of these individuals actually could leave the asylums that we had created for them. So in 1950, chlorpromazine was synthesized. It is an antihistamine, and it tended to sedate these individuals. 1952, chlorpromazine reported to be beneficial in psychosis and in mania. So people that were severe, reacted severely to bipolar disorder or the people that were suffering from schizophrenia, all of a sudden we knew that we could treat them, we could sedate them. 1953, first reports of chlorpromazine-associated movement disorders. This is the tardive dyskinesia. We're going to talk about that in a minute. 1958, haloperidol was developed. 1962, long-acting injectable fluphenazine was developed. 1970, dopamine hypothesis of schizophrenia was suggested. Before this, we had no clue. Now we could treat people with that if it increased their dopamine level, then we could control their behavior. In 2005, the CADDY trial shows positive outcome for fluphenazine compared to newer antipsychotics. So here you go. Neuroleptic means seize the neuron, referring to the tendency to cause stiffness and other neurologic symptoms. What we normally did in the 1950s and 1960s was we dosed them and put them into neurolepsis, and then we backed off the dosage until they were functional. It sounds horrible, doesn't it? It was. Major tranquilizers refers to the tendency to sedate, quiet, and create a blandness in patients, similar to the negative symptoms of schizophrenia. Differentiates from the benzodiazepine, the Valium, etc., which were referred to as minor tranquilizers. Benzodiazepines did not work on people with who were suffering from schizophrenia or bipolar disorder. They were the minor tranquilizers that we used for anxiety. So we needed major tranquilizers. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonist highlights strong dopamine activity and tight binding to D2 receptors. So what we assumed was going on with the when we came up with the 1970s, we assumed that these individuals had too many dopamine receptors, and that's what was causing their psychosis. So we started giving them antipsychotics that tied up the D2 receptors so that they wouldn't act psychotic anymore. The side effects of this terminology, sometimes we had extrapyramidal symptoms, pyramidal system responsible for voluntary movements, extrapyramidal system responsible for involuntary muscle action, It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. This is what tardive dyskinesia looks like. It's tics. You have involuntary movement of small muscles. Acute dystonia is sustained muscular contraction of neck, eyes, and throat. Generally occurs soon after starting your medication. They go into tardive dyskinesia. Akathisia is uncontrollable continuous motor restlessness. It can occur anytime in treatment, but generally it happens in the first weeks after taking the medication. It's easily misdiagnosed as underlying psychiatric disorders. Parkinsonism, tremors, muscle stiffness, slowed movement, and drooling generally occurred within the first week of medication. Tardive dyskinesia, spastic facial distortions, and tongue movements may extend to neck, trunk, and extremities. Delayed effect, usually beyond 6 months from starting medication, and these are some tardive dyskinesias. Risk increases with duration of exposure to antipsychotics. It's known to occur without antipsychotic therapy. It may be permanent. It occurs on discontinuation or resolves on its own. Is worsened by medications used to treat other EPS symptoms. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremor, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities, elevated white blood cell count, and CK. CK is creatinine phosphokinase. It is a enzyme that is released from working your muscles. Back in the old days, before we could measure what was going on with your heart, if we thought somebody had a heart attack, we would measure their CPK level or CK level. Now they call it CK. They used to call it CPK. It's creatinine phosphokinase, and it is an enzyme that is released when you work your muscles a lot. So if you had muscle damage to your smooth muscles in your heart, your CPK level would be higher. Now we can fractionate those. We can tell which enzyme is your smooth muscles and which is your striated muscles. CPK. Mortality of the neuroleptic malignant syndrome is 10 to 20%. It can occur anytime in the course of treatment. Anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, mydriasis, dilated pupils. Clinical effect and potency, low potency, antipsychotics, chlorpromazine, mesordazine, thiordazine, medium-high sedation, low-medium extrapyramidal symptoms, high anticholinergic effects. Medium potency, perfenazine, loxapine, and melindone, Low-medium sedation, high extrapyramidal symptoms, low-medium anticholinergic effects. High potency, flufenazine, trifluazine, trifluoperazine, thiothiazine, haloperidol, and pimazide. Medium low sedation, high extrapyramidal symptoms, and low anticholinergic effects. So why are we talking about all of these different sedating substances? It's because the more severe you are, the higher the potency you get. Hopefully, you're giving somebody the lower potency anti-seizure medications. But if they are severe or they're not reacting to the lower potency, then you go to medium potency, and of course the people that are the hardest to control, you give them the high potency anti-seizure medication. Chlorpromazine, thorazine is there's a cardiac risk and weight gain. Fluphenazine, prolazine is long-acting injectable. Halperidol or Haldol is long-acting injection available. This stuff is one of the high-potency drugs. Loxapine or Loxetane, we didn't talk about that one. Marazodazine, Serentil has cardiac risk. And of course, these are all the problem. I mean, these are heavily sedating. These are sedating medications, so there could be complications. And this is one of the reasons why, when you're giving somebody an antipsychotic, you've got to watch them very carefully because you can put them into cardiac arrest fairly easily. Melindone, Moban, Porphenazine, Trilofan, Pimazide, ORAP. There's cardiac risk with that as well. Meloril is a very common one that we use. It's a very strong sedating medication. It has a high cardiac risk. Navane, thiothiazine, and stelazine. The newer antipsychotics in 1990, clozapine was introduced in the United States after a long delay related to safety concerns. This is clozapine came out of Europe, and there were a lot of safety concerns. 1994, risperidone was developed. 1996, olanzapine, and we're going to get a series of different medications that are very similar. Risperidone was the first one, then olanzapine came out a couple of years later. Quetiapine came out a year later. 3 years later, ziprasidone. 3 years after that, aripiprazole. 2004, the ADA, the APA consensus report on obesity and diabetes in those taking antipsychotics came out. They realized that they were creating other medical problems by giving them antipsychotics. Terminology: atypical antipsychotics or second generation antipsychotics or serotonin dopamine antagonists. These are the newer antipsychotics. The mechanisms: it adds serotonin activity into the mixture, so you're not only getting an antipsychotic effect, but you're also getting an antidepressant effect. It binds more loosely to dopamine receptors. Clozapine, initially rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of EPS. Indications and uses of the newer antipsychotics, and you see these on television all the time, strangely enough. And they are suggesting that you give the antipsychotics for depression that doesn't react to antidepressants. So indications of using the newer antipsychotics: schizophrenia and other psychotic disorders, of course, acute bipolar mania and maintenance. So the two psychotic mental illnesses. Augmentation of antidepressants and mood stabilizers. That one drives me crazy. Aggression and impulsivity. It seems a little weird to me, and this is just my own take on things, but it seems a little strange to me that that we're always looking for a magic pill, and the antipsychotic drug is it does look like a magic pill. But you should try to not take as many medications as you possibly can. You should try to reduce the medications. Features: less risk of EPS movement disorders, greater effect on negative symptoms of schizophrenia. Cautions: greater risk of obesity, diabetes, and lipid abnormalities. So you're treating one disease and you're actually creating more problems. Clozapine effects, olanzapine effects, quetiapine, risperidone effects, ziprasidone, and aproprizole. Requires regular monitoring of metabolic parameters, potential stroke mortality risk in the elderly. So you got to be really careful who you're giving these medications to. EPS disorders and NMS all can still occur, although much less than with typical antipsychotics. Abilify, you see this one on television from time to time. It has a unique complex of mechanisms, can be either activating or sedating. Nausea is common with Abilify. Let's just call it Abilify. Clozaril or clozapine, most effective antipsychotic. Risk of agranulocytosis, decreased neutrophilic WBCs. Your neutrophilic WBCs fight bacteria. We talk about lymphocytes all the time. Lymphocytes fight viruses, but your agranulocytes, your neutrophils, fight bacteria. So strep throat, Staph aureus, these are your bacteria. These are the ones that invade your body very rapidly and have to be defeated right away. They cause abscesses and whatnot. Viruses usually cause long-acting diseases. Um, Tuberculosis is a bacteria. Strep throat is a bacteria. When you cut yourself and get an infection, it's usually a bacteria of some kind. E. coli causes diarrhea. Most of your diarrheas are caused by bacteria. Mumps, measles, chickenpox, those are all viruses. So you need all kinds of white blood cells, and this causes it reduces your number of white blood cells that fight bacteria. CBC weekly for 6 months, biweekly for 6 months. This is Clozaril. Really messes you up. Multiple other side effects and direct drug interactions. Levels reduced by smoking. So this is one you got to watch. Olanzapine, Zyprexa, Zydus, significant weight, diabetes, and lipid abnormality risk. Levels are reduced by smoking once again. Quetiapine, Seroquel, approved dose range considered low by many. Low EPS risk, used commonly as a sedating agent. Risperidone, Risperdal, most typical antipsychotics at higher doses. Available in long-acting injection, known as Consta. Ziprasidone or Geodon is approved dose. Range considered low by many. Initial cardiac concerns appear insignificant for most. Must be taken with fat-containing meal. Okay, now these are the anticholinergics. This is this is for a lot of different things. Congentin is least sedating, most commonly used. It fights Alzheimer's disease and dementia. Piperidine, akinton, diphenhydramine is Benadryl, arahexafenadil is Artane, and amantadine is Simitril. It's not an AC. It's used rarely to treat EPS. It treats extrapyramidal symptoms, tremor, stiffness, drooling, dystonias. Akathisia may not respond to ACs. Tardive dyskinesia may worsen with ACs. Dry mouth, constipation, blurred vision. EPS thought to be cholinergic dopamine imbalance. The benzodiazepines, Librium or diazepoxide was developed in 1957. 1970s, Valium was diazepam was developed in 1970s. For the longest time, Valium was a leading medication used in the United States. It was replaced by selective serotonin reuptake inhibitors, and then by Viagra. 1986, Xanax, alprazolam, became the top-selling drug in the United States. And then in the 1990s, SSRIs replaced some of the chronic benzodiazepine used for anxiety, and it became the leading medication in the United States. General characteristics of benzodiazepines differs in action, duration, drug-to-drug interactions, and side effects based on differences in absorption rates, lipid solubility, and metabolism. Indications uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawal, muscle spasm, agitation, catatonia, akathisia. Hospital use, they can give it to you either as an IV or in injection. Side effects, sedation, cognitive impairment, anterograde amnesia. They hope. They hope you'll forget the pain that you were in. Respiratory depression at high doses or with alcohol. It may worsen obstructive sleep apnea symptoms in susceptible individuals. Abuse and dependence. Risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of longer acting agents to minimize between dose breakthrough and avoid taken as needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of the underlying anxiety disorder, and this is a problem. You can't just stop taking benzodiazepines. You're going to have a rebound effect. Needing to increase the dose, tolerance not generally an issue at therapeutic doses. Alprazolam Xanax is short to mid. It lasts for a short period of time or mid. Chlordiazepoxide, Librium is long-acting. Clonazepam, Klonopin is mid to long acting. It's a serotonergic. Chlorazepate, Transine is long-acting. Diazepam, Valium is long-acting. Estazolam is also known as Prosom, is middle-acting. Flurazepam, Dalamine is long-acting. Lorazepam, Ativan is short to mid-acting. Oxazepam, Sirax is short to mid as well. Temazepam, Restoril is mid-acting. And triazolam is Halcyon is short-acting. I've told you before that during the Vietnam War, a lot of they were giving Librium and Valium by the bucket load to individuals. Mostly had to do with trying to control their anxiety levels. These were mostly the wives of military members. This is one of the ways they were controlling people in the or controlling the wives, I guess. They're trying to keep them from going berserk. There were enough people that were anti-war. It was kind of a strange situation. Other anxiolytics or hypnotics, chloral hydrate was the first that they came up with in 1969. Ambien was approved in 1992. And Zolpidem, it's a generic Ambien, was approved in 2006. Hypnotics are medications that induce sleep. They're non-benzodiazepine anxiolytics. It includes buspirone and antihistamines. You can take antihistamines that will actually knock you out. Newer anticonvulsants are used off-label as both anxiolytics and hypnotics, although efficacy is unproven. Trazodone and some tricyclic antidepressants are used as hypnotics. Neurohypnotics active at GABA1 receptor except Rameltion. Other anxiolytics and hypnotics, miscellaneous, bispirone, Buspar is a subtle anxiolytic and it's slow to respond. Chloral hydrate is 3 molecules of alcohol stuck together. It knocks you out, and it's also known as Noctec. It's used as a hypnotic, as a rapid. You develop a rapid tolerance to it. It's like alcohol, and you got to be really careful. You certainly don't want to take it with alcohol. It could kill you, and so you got to be careful. Antihistamines, hydroxyzine, pamoate, Vistaril, and diphenhydramine, Benadryl. There's Benadryl right there. It's an antihistamine. Anticonvulsants, mildly sedating and calming, Neurontin, Lyrica, and Gabatril. You might have seen these on television, especially Lyrica. It's an anticonvulsant. They want you to take it for bipolar disorder. Selective benzodiazepine receptor activity, GABA1 hypnotics, Lunesta is a sleep aid. It's a long-term use approval. And of course, you got to be really careful with these because you can become addicted to them. Lunesta, Sonata, and Ambien. Melatonin receptor agonists, Rosaram or Meltion. Okay, now we're going to talk about the stimulants, ADHD drugs. 1956, Ritalin was approved. 10% of 10-year-old boys in the United States are on stimulants of these kinds. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants. Endomoxetine, Strattera these are all drugs for ADHD. Non-stimulant treatment for ADHD, recent caution about suicidal ideations, rare liver function impairment, but it does occur. Clonidine, Catapres, it's an antihypertensive alpha-2 agonist. It's used for ADHD, substance withdrawal, Tourette's syndrome, and other problems. Pimeline, Cylert is rarely used stimulant due to liver toxicity. It's used for ADHD as well. Dextroamphetamine, dexedrine, is a multiple long-acting form of stimulant. It causes insomnia, headaches, tremors, exacerbation of tics, nausea, weight loss, blurred vision, and overstimulation. So it's a amphetamine. Methylphenidate, Ritalin, has the same reactions as dextromethorphan. I'm sorry, dex, dextramphetamine, modafinil, Provigil is a non-stimulant. It's poorly understood mechanism of action. We have no clue what's going on. It's used for sleepiness related to narcolepsy, obstructive sleep apnea, depression, multiple sclerosis. It's used for ADHD as being investigated. Provigil. Okay, now these are medications for dementia. The first one I can remember when Cognex first came out. Tacrine Aricept was the next one that came out in 1996. Donazepam, Aricept is what we called it. 1997, generalizability of approval studies questioned. Cognex and Aricept, they didn't seem to be causing, they only helped for the short term. 2003, Namenda was approved for moderate to severe Alzheimer's dementia. 2004, detailed British study questions efficacy of cholinesterase inhibitors. General characteristics of medications for dementia. The search for a treatment for Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. Studies that support use of these medications generally find subtle benefit or slowing of decline. Sorry. There is significant debate about the benefit versus cost, the money and side effects of using these medications. Treatment for behavioral issues and dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly. Cholinesterase inhibitors address one theorized mechanism of this complex disease. Donepezil, Aricept, galantamine, Rimonil, Vastigmine, Exelon, Tacrine, Cognex, rarely used due to liver toxicity. And this is one of the things we discovered. I can remember when it first came out, everybody was going, oh, this is great. Now we've got a medication, Grandpa, we can give it to Grandpa and he'll be lucid again. And one of the things that happened was that it, especially if he had been a drinker at some point in his life, it blew his liver out. Memantine, Namenda, complex activity via NMDA, glutamate-mediated receptors. It may have more broad psychiatric application, and we're not exactly sure. Actually, they've been giving people Namenda to help their memories, whether they have dementia or not. So that's a question. But anytime you take a medication, you've got to figure that something else is being affected. And you have to be really, really careful. Use of medications in substance abuse, treat withdrawal symptoms, benzodiazepines, anticonvulsants, clonidine, treat comorbid psychiatric disorders, anxiety and depression are common, selective serotonin reuptake inhibitors, mood stabilizers, and benzodiazepines. One of the things that we know is that people are self-medicating with marijuana. They self-medicate with alcohol and nicotine, of course. A lot of these people are depressed, and that's why they're trying to change the way their brains are functioning. They're trying to increase their happiness. These medications are used to prevent relapse, deterrence, and craving control. And these are drugs that we're taking to help treat substance abuse. Disulfiram antabuse is a deterrent. It requires motivated patient. It makes you vomit if you drink alcohol. Acamprosate, Camprol, it controls your craving. Has minimal drug-to-drug interactions. Efficacy shown in some studies with more severe alcoholics, although other studies question efficacy. Naltrexone, of course, Revia. It's an opioid antagonist. It has a high response for placebo, causing some to question its study design. Potential liver toxicity. Vivitrol injectable naltrexone lasts for about 30 days. Of course, we have the spray that you spray up in their noses. Buprenorphine, naloxone, suboxone is a treatment for opioid dependence. Contains both an agonist and an antagonist. Bupropion, Zyban is identical to Wellbutrin. It treats nicotine cravings. Others, several anticonvulsants, topramate, etc., have been used for craving reduction, and sometimes they work and sometimes they don't. The uses of these drugs are off-label and carry additional potential side effects from their cardiovascular actions. These are psychiatric uses of antihypertensives. Potential psychiatric benefits have been often been discovered while these agents were used for their primary indication. You have to monitor their blood pressure to make sure that it's not going too low. And these are the three major antihypertensives: alpha 2 adrenergic agonists, clonidine, guaifenesin, prazosin. It's used in ADHD and Tourette syndrome and PTSD. Prazosin is found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol, used for akathisia, lithium-induced tremors, performance anxiety, and aggressive behavior, hyperarousal. Pindolol has been considered for antidepressant augmentation. Multiple drug-to-drug interactions avoid in asthma, diabetics, or insulin. Certain cardiovascular diseases, beta blockers. Calcium channel blockers, diltiazem, verapamil, nimodipine may be helpful as additional agent in bipolar maintenance, multiple drug-to-drug interactions, and precautions, and that is it. Okay, sorry about that. Well, it's been a long 10 weeks. No, it hasn't been 10 weeks. 8 weeks. So, sorry about the congestion. We got lots of. It's that time of the year, though, I guess. So, I'll see you guys later. Wait a minute. I can turn on the light. There we go. Good luck. Don't forget to get your paper in. You have until the 8th of May to get everything in. That includes all of your that includes your paper and all of your article critiques. You can take the quizzes. You have until the 8th of May, okay? That gives you another couple weeks. Gives you exactly 2 weeks. So there you go. Thanks a lot for taking the class. I hope you had a good time.